There we go. Okay. So hi everyone. For those of you that don't know me, I'm Anton Nicolene. Along with Eric Walser and Ian Ball, we started this program called Southwestern Ontario Critical Care Series, or SWOCCS. Thank you for joining us. The point of SWOCCS is to try and provide practical and topical CME topics for Southwestern Ontario critical care providers. This is credit under CME. We want to try and improve the collaboration in the area and some of the cooperation with our critical care centers throughout the region. And then we also want to share common challenges and strengths between the great critical care groups we have throughout Southwestern Ontario. We have some great speakers today, but I do want to take a second to congratulate my partner in crime here, Eric Walser, who unfortunately can't be here because apparently he operates. But he will be joining the LHSC staff as an intensivist and general surgeon coming August of this year. So very lucky group. As far as speakers today, we're going to be discussing tracheostomies with two of the great physicians already at LHSC. First, we have Dr. Leeper, who is an intensivist, trauma surgeon, and general surgeon at Western University, where he also serves as the director of the Royal College Surgical Foundations program. Dr. Leeper completed his residency training in both surgery and critical care at Western University and his fellowship training and Masters of Education at the Johns Hopkins Hospital in Baltimore, Maryland. Dr. Leeper is particularly enthusiastic about medical education, and in particular, the use of high-fidelity simulation to identify latent safety threats to patient safety and improve team-based crisis resource management. Dr. Leeper's research interests include resuscitative and surgical applications of point-of-care ultrasound, as well as surgical outcomes research in the broad areas of trauma and emergency general surgery. Today, he's going to be on the pro-tracheostomy side, as he's pretty sure that there isn't a problem a trach can't fix. Dr. Cameron, on the other hand, is an intensivist at Western who attends in the critical illness recovery program at the University Hospital, along with the medical surgical unit and the cardiac ICU, as well as home ventilation. He was my program director and is a great educator, but does take a nihilistic approach. And so we're very thankful that he's going to be taking the con side and saying, trachs don't do nothing. I'll hand it over to Rob to start off the talk.
Yeah, I should point out that in terms of simulation and latent threats to patient safety, we're still doing the same sim program that Anton served when he was here as a fellow, and it's great. So I really have an Anton shadow in that world. He does an amazing job. So I'm gonna grab some slides here if I can get them to pop up. You'd think I would know how to work Zoom by now, but when I launch my slides, then it's the wrong display setting. So hold on, here we go. So I can't see anyone anymore, but I hope, can you guys see my slides? Maybe?
Looks good,
Anton?
Rob.
Oh, great. So, honestly, thank you for the intro, Anton. I think you said who we were, Paul and Rob, and did a great job summarizing. I would sort of cast, the roles a little bit like the same, but maybe just a little like different bend on it. I would say if it's a Venn diagram of Paul and Rob, we overlap for sure. Paul brings that nice medicine world to things. I kind of maybe a little more surgically minded and the middle critical care. And so you'll hear, like an entirely fraudulent and fake debate about tracheostomy because we both kind of feel the same way. We just look at it from a sort of a red and a green lens. And I think the data and our practices are actually much more aligned than we would like we're going to pretend they are. It makes for a better talk if we sort of, plant a flag and stump for our side of the debate if there is one. So the outline for today is as follows. Paul and I chatted about this, and we'll kind of cover three issues. Issue one, probably the most, the pro-con part of it. And we call it, and the way to make this pro-con is to say, is it early versus late trach? Do you kind of hurry and do the ones you think are needed? Or do you say, you know what, let's just wait and see, continue current management, and we'll trach them late if they really need it. And we'll kind of talk about what the evidence is for both those sides of the coin. And then I want to give the mic to Paul. He'll pull his slides out and do a little bit more talking. Again, I hope a good interest for our group on how we are working on a post-tracheostomy weaning protocol, kind of a weaning strategy that is one size fits all, if you can imagine that, and adaptable and useful for solving the problem of being on a ventilator. And then the third thing will come back to me, and I'll just do a little quick 5-10 slides max on troubleshooting tracheostomies, looking mostly at bleeding and kind of dislodging, dislocation of trachs, because it's a common couple of calls we would get, or trouble that anyone in the ICU might see with a trach. I'll just walk you through how I think about them, how we problem solve them, and what the common causes and solutions are. So with that as the intro, here's the first topic. Issue 1, trach timing. So we had a coin flip. Paul won. He deferred. I took the ball. I'm going to start with my very brief, I hope very simple surgical, if you will, thinking on trach timing. So I'm going to do a very simple review of what is actually a pretty homogeneous literature. I mean, Paul will get into much more detail than I will, but I'll give you my overview. I'll give my practical approach to how I talk to families in light of what literature says about trachs in the ICU. And then I'll give you a couple of not in the textbooks observations from my practice and my experience about care and about what trachs do, that isn't maybe a bit of between the lines look at how trachs, I think, help in the ICU. Okay, so again, simple, almost infographic-like. I'm going to go through 3 or 4 papers. The first one, I'm sure I'm pronouncing it wrong no matter how I try it. I would say probably it's Pier Paolo Turani, I would guess. The G must be silent in Italian. And this is a paper that I love because it came out and was reviewed by me in my first year of fellowship in the ICU, way back in the 2010-ish era. And like a lot of the literature here, it's at RCT. It was done in Italy, as you can imagine from the names on the chart. And what it showed, I kind of have the same bar across the bottom of the screen, sort of just to give you the infographic preview. Mortality, just no smile, no frown, the same. Pneumonia rate, no smile, the same. Vent days and ICU days, significant difference. So people who got trached early, in this case, it's a 7-day versus a 10-day and beyond cutoff, clearly got out of the ICU faster and were off the vent for more days in the first 28 than their counterparts. So again, not a plant your flag, everyone gets a trach trial, but it showed the direction that the literature would kind of take in the years to come. Now, TracheMan took a bit of the shine off that apple. British trial. They just imitated basically the work done in Italy, but kind of tightened up a little bit. They went for an ultra early trach, 4 days only. To me, I think if you can poke holes or say there's a lack or a breach in external validity, that's really early. It's earlier than I would really ever trach somebody outside of certain circumstances. And so in this trial, once again, it's at RCT in I think 900 patients in British ICUs. Mortality and VAP, which is consistent, no change. This is not, they're not doing a lot for patient-important outcomes. But vent days, this guy's kind of frowning, only a trend towards better vent days. So also known as not significant, and ICU days not significant. So an ultra early trach in the TracheMan trial kind of made no difference. Probably the best systematic review on after those trials is now 10 years old. It's a Cochrane review. Again, it's an Italian group, so maybe they're favoring the Italian data. They showed up, it surprised me, it's the only trial that I think is out there that shows a mild mortality benefit. There have been sort of more niche subgroup looks at just neuro patients, just trauma, just cardiac. This is the only one where the pooled analysis showed a slight 8 to 9% number to treat of 11. That seems too high to me. Mortality benefit, but they did show one for what it's worth. VAP, no difference. And again, the signal comes through as vent days and ICU days. You tend to lower the amount of time on a ventilator, less sedation they showed in these trials too, by doing an earlier trach. So, in terms of now my practical approach talking to families, when I talk to families, I say, hey, this is a common procedure. It's a safe procedure. It's not every day. It's not that different than a central line, a bronchoscope, or anything else you do in the ICU. The outcomes are system important. They're not patient important. I don't tell them it's going to save their lives. I don't tell them it's going to reduce infection. I say it's going to get your family member off the ventilator faster and get them out of the ICU faster. And I do think that being on a ventilator is a disease, and our job in the ICU, by and large, is to recognize that we are fighting a clock and then every tick that goes by is costing the patient something, suffering, comfort, delay in their care, etc. So I pitch it that way. And the kind of the not in the textbooks things I noticed, it's funny. I'll just some simple observations, and anyone, all my colleagues, I'm happy to see all the RTs are here and Brenda. When I start to talk about traching a patient, I'm amazed by how suddenly they become easier to wean and require less sedation. And it's almost like a reverse psychology thing that my colleagues who do a lot of bedside care and my RTs and nurses are like, you know what? No, we'll get them off. Like this, it's kind of like a challenge. You put okay, by Friday they have to be off the ventilator. We're traching them. Okay, let's do it. So it kind of like it's a team bonding thing in a way. And for sure, if I get to Friday and they get a trach, after the trach, my personal experience is the number of the amount of sedation that's required goes down. There's a much better tolerance for wakefulness and like less restraints, and that probably is a patient important outcome. And it's certainly, I would say, everyone is more comfortable after a trach. The nursing staff, the patients, just there's something about a secure area that's sewn to their neck and tied on that makes us feel like okay, now we can be more liberal. Now we can be a little more, you know, ambitious with our patient care. And I like that. I think that's a good thing. So I just say, you know what? I recognize the data, and of course, pulmonary toilet remains to me the number one enemy of my post-extubation patients, and the number one benefit I think of tracheostomy. And I love Kristen and Jen. Don't yell at me on the call. I love you guys. You're great, but you cannot beat a suction catheter banging against the carina. The world's best chest physio is good, but when the catheter hits the carina through a tracheostomy and they cough with all their might, it doesn't matter how sore your ribs are or how much you want to participate in care, you will cough. And that pulmonary toilet, I think, keeps you off the ventilator and out of the ICU. That's a big secret weapon on the tracheostomy. So those are, again, this is just my personal observations of trachs. So I just say at the end of the day, to paraphrase Morgan Freeman, our job in the ICU is to defeat the disease of being on a ventilator. Trach is a great tool for that, not the only tool. So in my mind, it comes down to a simple choice. You either get busy extubating or get busy traching. And with that, I will pause, stop sharing, and kick it over to Paul for his side of the never do trach extubate. They're terrible. Paul, is that okay with you?
Let's go. Yeah. So yeah, I'm Paul Cameron. Thanks to Anton for the introduction. Thanks to Rob for presenting his part. And I certainly was concerned when I was going to go into this pro-con debate that I'd have to really be strategic and cherry pick the evidence that led to my side, make this interesting. But really, as I think Rob's already articulated, the evidence kind of did it for me. I'm going to try and make the point that really the idea of tracheostomy timing relates to probably one of the hardest things to do in the ICU, even just doing nothing. So sitting on your hands and watching, prescribing time for patients, understanding that a disease of respiratory failure or improving from cardiac arrest takes an amount of time, and that if you're not going to make somebody live longer and you're not necessarily going to make them leave the hospital in better situation, you just have to wait, and there's no benefit to proceeding, but that's very hard, which is why we get busy traching instead of get busy waiting. I will go through probably the pivotal trial. This is not the SCAT-MAN, but this is in fact the TracheMan trial. TracheMan was published in 2013. It's probably the biggest, most well-known trial in this space, and published in JAMA by Brian Cuthbertson, who's now in Toronto. This looked at all comers in the ICU. They were enrolled within 4 days, and as Rob articulated, scheduled to undergo trach within 4 days or not before 10 days. I'm not going through a systematic approach to this, but the interesting things are this was predominantly medical. So this was, say, 80% medical patients. And of all the patients, 70% had a pulmonary reason for being intubated, which I think is super relevant as we get forward to the end of how to interpret this data. And they excluded people with chronic neurologic problems or emergency problems. This yielded the Kaplan-Meier curve that you're familiar with if you've ever done any ICU research. This could actually not be from TracheMan, and none of you would know because every Kaplan-Meier curve in critical care looks the exact same. But there was no statistically significant difference in the cumulative survival at any time point, which I've shown here. So we have the outcomes of mortality here, 30 days at ICU discharge, hospital discharge, 1 and 2 years. You have the early group, and you can see this was a pretty large large trial by ICU standards with almost 1,000 people versus late with the absolute risk reduction and p-value in the fifth column. Don't spend too much time looking at all these numbers other than there's nothing that's significantly different. What I think is interesting that informs a lot of our discussions, and I think also counseling towards the end of this, is sort of similar to the CRT trials. The 1-year mortality in people that get trach is high. Our unit mortality at LHSC is about 25 to 26% between sites consistently over years. And I think that this sort of informs us that if you have a situation where you are being considered or receiving a trach, there's a pretty good chance that that person at 1 year may not have a good outcome. So I think this informs our counseling. What's interesting and is always worth extracting, and I'll point out to some of these trials, is in the late group. So this was the group that was assigned to not receive a tracheostomy before day 10. You can see here how that broke down. 46% of people received it. So most people in the late group do not actually get trached ever. 20% were discharged to another ICU, 17% of those were extubated, and 12% died. So the combination here is about 30% of people died or were extubated before the time when they'd be considered for tracheostomy. This kind of points to another problem, which is the idea in the randomization, you had to project a 7-day course of invasive ventilation at day 4, and a decent chunk of these people are extubated before then or die. And so our ability to prognosticate who's going to require tracheostomy or require prolonged invasive ventilation is poor. Now, this was predominantly in a pulmonary group. What about a neurologically injured group? That informed one of the more recent and large trials that informs this question, which was the SET Point 2 trial. This was patients who were receiving invasive mechanical ventilation after an ischemic stroke, intracranial hemorrhage, or a non-traumatic subarachnoid hemorrhage. The SET score is a predictive modeling-based score that predicts the need for tracheostomy. So these are people at high risk of being perceived to need a trach. They excluded anybody with even a limited amount of functional disability, people who were ventilated over 4 days, and then people who were end of life or withdrawal of life-sustaining measures planned. They were randomized 1-to-1, and this was a trach within 5 days, so close, but a bit longer than the previous one, and then similarly not before 10 days. Their primary outcome, as in many stroke trials, was grade on the MRC, and I've just shown you here what that scale is. Higher numbers are worse, 6 is dead. And so what this trial looked at, so they had about 200 people, well, not quite, 189, 177 in the respective groups. You can see here, too long didn't read, there's no difference in the primary outcome of survival without severe disability. So the MRC 4 and higher group was not statistically significantly different. You can see here that there was a higher proportion of death in the early trach group, but none of these was statistically significant. Interestingly, in the group randomized to delayed or standard trach, 22% of those were extubated and 11% died. Similar numbers to the TracheMan trial, but really no difference. And when they stratified these results based on age, sex, German versus US center volume of trachs or strokes, subtype, et cetera, there was no difference. And then there was also no difference in discharge destination, the cause of death, or invasive mechanical ventilation days. No difference in neurologically injured patients. But again, I want to come back to that point. Did I just cherry pick the best things? This is a more updated version of a systematic review and meta-analysis of this question. I'll draw a quick attention to the department at this University of Neuroscience, Reproductive, and Odontostomatological Sciences. I don't think that there's a chat here, but if people can think of what papers or what areas of research would encapsulate the reproductive odontostomatological sciences, I would be very interested. Seemed weird to me. Anyways, this was also in Italy, this was in Naples, and they did a meta-analysis. This showed at the bottom here, you can see that there was actually a statistically significant difference in favor for mortality in the random effects model for early tracheostomy, which is not really supportive to what I'm saying. However, there are some interesting points here. There are only 2 trials that actually in and of themselves showed a benefit in the trial itself. So this sort of gets to the question of these are small studies, 50, 60 people. You can see the relative weighting here is very small studies themselves negative, but when aggregated and meta-analyzed, they show a positive result. I've shown you the two highest weighted studies. Rob showed you the Terani study, which is up here, the 10.46% weight. The other ones that were positive, I'm going to talk about the two of them briefly, just to sort of give you a reasonable perspective. What's interesting here is this was early versus control or late tracheostomy. When they actually analyzed the studies that did early versus never tracheostomy, so people that just never got trached and you waited until they were weaned, there was no difference in any outcome: mortality, VAP, ICU length of stay, hospital length of stay, days of invasive mechanical ventilation, which is even more interesting than the early versus late question. Anyway, the Rumback study, this was done in 2004. This was the one that had the highest point estimate and the narrowest confidence interval. It was a study of 120 patients in Memphis and Tampa who were invasively ventilated for respiratory failure. Normal exclusion criteria excluded people over 48 hours of ventilation or people over 12, and they had to be trached within 2 days or 14 to 16 days. So we had 120 patients. These are the results. Significant decrease that wasn't significant as mentioned in terms of death. So the top row here is 32% death versus 62% death. Pneumonia was significantly reduced. All their outcomes were statistically significantly reduced. What is hard to believe about this, and I'm glad they did more studies, is a 62% mortality for patients admitted with respiratory failure is stunningly high. And so it may reflect either a difference in that patient population or we've adapted our practice patterns over the last 21 years. What's interesting, and I think we haven't talked about much, is why ever trach people? What's the problem with just leaving people prolonged endotracheal intubation? And one of the big risks that's brought up is supraglottic or is airway stenosis. This looked at tracheal stenosis rates, and this chart shows the tracheal stenosis percentage, 0 to 20, 21 to 50, or over 50%. In hospital are the first two columns, then 10-week evaluation, the second two. Take-home point here is there was no significant difference in tracheal stenosis percentage based on leaving on the late group. So the people that had prolonged translaryngeal intubation, the late trach group, did not have a statistically significant increase in tracheal stenosis rates. The numbers are quite small. The last one I'll sort of talk about briefly that was positive, or at least that influenced that positive meta-analysis, was in COVID. You can see here the title of it. I'm not going to dwell on this because the study itself was actually negative, but they randomized 150 people in Sweden who had COVID, projected invasive mechanical ventilation course of 14 days to trach within 7 days or not before 10 days. It was pretty small range there of difference. And I'm just going to show you the flow diagram here to highlight what point that I'll make in the next slide, which is 34 patients in the late trach group did not get trached out of 78. Interestingly, only 27 in the early trach group received this. So I think that this study it was done intention to treat and per protocol, which both showed the same results, which was nothing. But it hints to me that we probably have a need to identify people who are going to require prolonged invasive ventilation and who are not going to die before we start being more diligent with standardized approach to tracheostomy timing. As I mentioned, the primary outcome, I didn't, but all the outcomes were not statistically significantly different. The primary outcome was total days of invasive ventilation. Again, we're traching at 7 versus 10 days, and there was no difference in the total days of invasive ventilation from a statistical perspective. So that's sort of a review of the literature. What's my approach and how is it informed? I think it's important to know when you're in this day range of maybe 4 to 10 days, you're never going to need a trach in about half of the people that you at the present moment think you will. Now, there might be, again, a reason to be more diligent, more thoughtful, better at predicting. Maybe we can use machine learning to help us identify people, something that's more interesting. But right now, if you're squinting and saying, my gut sense is this, you're probably going to be wrong about the need for this about 50% of the time. I think that the VAP rates, which is potentially considered here, are unchanged because an artificial airway is an artificial airway. It disrupts the normal barrier function, the normal mucociliary clearance, and so you're going to still have VAPs. I think the mortality is probably equivalent, and I think my co-debater would agree with that. Whether there's structural damage, I don't think any of the big studies that are randomized control trials are adequate to comment on this. I'll just say that a lot of the literature behind airway stenosis and chronic problems came from an earlier era of tracheostomies when the cuffs were much lower compliance. And I think ICU length of stay depends, which I will elaborate on. How do I decide to trach people? If people are as clear as we can get, GBS, diffuse axonal injury, people who are on ECMO, there's a very, very high degree of certainty that they will both need prolonged invasive ventilation and that they might be able to be weaned off of the positive pressure quickly. As long as their goals of care are in keeping with like a 6-month recovery, you might as well just get on traching, as Rob said. So I'll concede on that point. If there's an unfair diagnosis or prognosis, I think that this is fair. There's no clear benefit until you know exactly what's going on. If this is sort of a neuro, autoimmune cancer, we're diagnosing them, I'd wait. The sort of protean diseases in ICU, if you have post-ROS, but you're not fully awake, your prognosis isn't minimally conscious or persistent vegetative state, sepsis, septic shock, critical illness, myeloneuropathy, ARDS, I don't think that the evidence suggests that you're going to have a huge benefit. Where I think you can make this sort of argument and what my ultimate take home is you're not compelled to trach people early. You're not compelled to trach people at all, I don't think, but you're definitely not compelled to do it early. The people in whom, what you're compelled to do then is think about that patient. If they have a high probability, once you place that trach, you think they're going to be off the ventilator in 1 or 2 days, and you think that they have a neurologic injury that's going to require days to weeks to improve, I think it's worth just going ahead. That's the question I always ask myself. If we trach this person, are they going to be able to wean and then be discharged and realize that benefit Rob Leeper talked about of decreased ventilation days, decreased ICU length of stay? Someone's paralyzed on 70% oxygen on day 5. You could trach them, it's not going to change anything. There's no difference there. So there's no point because we're bad at predicting it. But if they're just on room air, neuro, toilet issues are for constraining them, it's reasonable to go ahead. And I put plus or minus toilet there because while it is a good suction technique, I don't think we need to be wedded to that as the only one. And then everybody else, if you think somebody is getting to that sort of, if I get to that 2-week mark, I think it's going to be at least another week. I think they're going to have a long period of invasive mechanical ventilation. Reasonable in all comers to start thinking about that. What informs my discussion, in addition to their values, wishes, et cetera, is some of the statistics. So in patients, as we discussed, if you require a tracheostomy for whatever reason, if you can't get over your acute illness by 2-3 weeks, there's about a 50% chance of that person being alive at 1 year. And of those people who are alive, about half of them will be at home. So that is often quite helpful, I find, to help people. And then using something like a standardized scoring system, the Provent 14 is a mechanism of projecting mortality at 1 year based on somebody's variables at 14 days. So you can just go, this is a very easy one. This is in the CCSO long-term ventilation toolkit. But what you see is that as you add points on, this is survival and then increasing points on these on these lines. As you get up to 5 points, your mortality at 1 year is 92%, 4.61, et cetera. So using something to sort of gauge that discussion, I would involve in trachs. The last point I'll make about this early versus late comes from this physician. His name's John Bach. I don't have time to go into too much depth about this gentleman, but quite a vibrant character. And there's a rounds he presented on our YouTube channel. But what he looks at is his point is that for neurologically injured patients, peripheral or central, you never need to trach. Trachs have risks, trachs have complications, which Rob will get to, but you just never need to trach anyone. And he does that by use of this protocol, which is basically using mechanical inexsufflation as a way to clear pulmonary toilet every 10 or 15 minutes. Families at the bedside doing cough assist every 10 minutes. This is something I always keep in the back of my mind. If I'm traching someone, could we not use cough assist and non-invasive ventilation? And would I be disappointing John Bach? So I'll pause there and then see if folks have anything they want to jump in with for Rob and I before we move on.
I agree, Paul. The rest of our talk's kind of boring. This is good. Like, I think this is a good time. If there are questions in the audience to ask, it's a good debate moment. And maybe go back to your slide on Paul's approach. I like that one.
We do have a Q&A section as part of the Zoom if anyone wants to ask in there, and there's 2 questions so far. But if anyone else wants to pipe up, there is also a hand function if you want to raise your hand here.
I will spoil much of the debate. Like, I think you could take Paul's approach and write Rob's approach. It's the same effing thing. That's how I think about it too. The only difference I would say is, Paul, I don't understand number 5. I couldn't imagine getting 21 days in the ICU without a trach. Who's is that something you think might withdraw? Like you're battling like a prognosis issue there? In your mind, who's 21 days with the trach? That's a weird time to trach somebody.
People with neuromuscular disease. So when we have the folks at UH who have polio, for example, or something like that, that we think like if we trach them, weaning them from, they're going to need positive pressure, cap, BiPAP. It's going to be so hard. Let's just wait. Let's just keep doing invasive until we get them to the point where we're able to go. That's the people that we see
like John
up
Bach,
to 3 weeks.
Dr. Bach patients who might need the rest of their lives, right? Okay, I gotcha. Or trach hurts here. I think, Brenda, you're off mute. Do you have a question? I feel like Brenda wants to talk. I can see you're talking. I think.
Can you hear me?
Totally can, Brenda. Go ahead.
Okay. Sorry, I'm trying to find a chat box and couldn't. I love your approach, Paul. Just I do think it's really important that yes, Rob, I know you do a lot of them and the risk is low, but they're not without risk. We see people get infected trachs. We see bleeding, but I do really like the approach of let's talk about what is the end game to this trach. No brainer if you're talking about somebody who's a high spinal cord injured patient, that early trach is certainly a better way to go. But it isn't without risk, and I mean we're not at the long-term ventilation site, but I have certainly had patients before where we're now trying to find a patient who has been trached, and then somebody just casually mentions to the family and and if they don't come off the ventilator, you can have long-term ventilation, which of course is a whole much bigger conversation. So I do really like, we need to really have an end game discussion, I think, in a lot of these patients before we go ahead with a trach.
Yeah, great point, Brenda. Same as dialysis, same as ventilation in general. Like before you take off, you got to know how you're going to land, for sure. And is there a question? I see Team Room at Vic has a hand up. Do you want to get them?
Well, there's 2 questions in the chat first, just because I'm trying to go in order. Paul seems to have answered one of them, so this was from Kevin Brown. In terms of data representing length of ICU stay and length of hospital stay, does this include length of time of reference, length of time with discharge to a rehabilitation facility? And Paul, I guess I'll just read your answer for now. This is usually unit specific, so transfer to a lower acuity unit capable of trach care or one capable of PPV with trach would be considered discharged. What your ICU/step down offer would be hugely important in interpreting length of stay data. I think do we know from the sort of studies you guys presented whether they included rehabilitation facilities?
I believe that those would be considered discharges from the ICU. So that would not be time, that would not be an ICU day if they're not in that physical unit where it happened.
The biggest black box from a trach man is the 20% sent to other ICU, right? Those are ones you lost to follow-up basis. Hard to say.
Yeah. And then Mihao, who's my colleague here, but previous Western grad, if most of the tracheostomy literature is from 10 years ago or plus, and we have since become more aggressive with SBTs, decreasing sedation, all that good A, B, C, D, E bundle, is the difference in vent time actually just us being more aggressive enough with low sedation and extubation? I think this is a great question. Interested what your guys' thoughts are.
For sure, Miha. That's exactly what I was driving at in my like not in the textbook observations. Like this is all managing us. It's not about the disease at all. It's about us. It's about how can we get ourselves as providers, doctors, nurses, RTs to be more comfortable, like letting them be awake, letting them go for the tube. But there's a great deal of hesitancy to let patients pull their own tubes out. But the trach is just so much more secure. Our comfort level rises up, and for sure over time, since CREST, we've been getting more and more aggressive, as you said, about being allowing patients more time off sedation. So this is all about a trach is just a tool to make us and the patient more comfortable with fighting the great battle of our time, which is the battle to get people off the ventilator.
Yeah. Thank you. Also, love this image. I don't know. Well, I mean, I didn't know that Paul wears green scrubs sometimes, but that's pretty interesting.
Well, actually, I have a message in the chat from I shouldn't say who. Let's just call him Andrew C. No, too obvious. A. Cadell. We just wants to know if Paul's taking time off his job managing a budget rental car, and does he know that shirts come with sleeves? These are the two questions he asked, Paul. I don't know if you want to respond.
I got nothing other than I wish I had boxing gloves in this one. Yeah, that's about it.
TC asked a question. I don't know if that's the hand up as well, but if you want to turn off your mute.
Does the team room have a question?
Hand is still up.
Maybe a legacy hand of some kind.
There is a question from the CCTC room in the chat as well, so I'll just ask that. Is there any evidence, RE, the difference in risk of delirium if patients are likely to be sedated without a trach?
I mean, everything we know.
No. Usually sedative dosing, like the cumulative sedative dosing decreases. That's obviously quite vulnerable to practices. Sorry, Rob.
I think we're saying the same thing. Like we know that the prolonged sedative dosing contributes to delirium. We know that for the majority of the studies that tracheostomy patients get reduced sedative dosing. So it's kind of I'm doing A plus B equals C there, a little bit of, but if you believe one and the other, then yeah, a tracheostomy should be a good tool to reduce sedation. That should be a good tool to help prevent and control delirium.
Okay. And the CCTC room has said they actually have two questions, but no mic. Their second question is, are there any increased risk of vocal cord dysfunction in patients with or without trachs?
There certainly is. There's a theoretical, there's a probable risk of vocal cord injury, erosion, ulceration from prolonged translaryngeal intubation. There are case reports of this. It's difficult to study at a meta level. That the box study where they never trach anybody after 6 months, 12 months, did not reveal like a horrendous level of surgically related problems, but that's a niche population where the risks are like they're probably not going to be swallowing or communicating a ton anyway. So I would say that it probably exists. It's difficult to have comprehensive data on that.
And you're trading off the risk of subglottic stenosis, right? So for sure, prolonged laryngeal intubation has been shown to be associated with cord injury, cord dislocations, and polyps and erosions and paralysis. But it's in that 1-2% range, similar to post-tracheostomy subglottic stenosis. So it's kind of like pick your poison. What's more important to you? That they're low risk, and you probably are trading off one for the other.
Great. Brenda just had one comment. So she said, some hospitals have trach teams for post-ICU support on the wards. This can sometimes be a challenge once they leave ICU as to who owns their trach at 3 a.m., what floor can take them, and how an emergency is managed.
It's a super great idea. So Brenda, I didn't put it in the talk, it's boring, but I just this month have a paper in the laryngoscope looking at comparing our trachs in the ICU to the trachs that are done by ENT in the operating room. And the follow-up and the mortality is totally different. Our patients are much more, a lot of times lost to follow-up or scrambled out to medical wards that don't have a great trach knowledge. So it's a gap. It's a big gap in our system, and I think it's an awesome idea to have. I know Andre's on the call. I don't know if Anna, we have We have two of the RT. I saw Veeams on the call too, but we're working to develop a post-trach follow-up, at least protocol, and some dedicated RTs who work here, who would follow along with those and be able to provide the follow-up care that maybe gets missed on a random medical service. Certainly, we always say call the service that placed the trach if there's a problem, and that's where my last couple slides on displacement and bleeding come in. But I think all too often it gets sent back to ENT just out of convenience or out of lack of knowledge. So there's a gap there, and we are working to close it, but it's not easy.
Great. One other question. In Toronto, they have an SLP and RT joint trach team from SLP. Just a comment from CCTC.
Same as that place. Lots of bigger centers that have more money to pay the salaries of non-physician people do a great job with trach teams. We had a full-time NP at Hopkins just for trachs. She was awesome. She was a publication machine. She was great clinically. They had like she organized interdepartmental meetings and research papers between us. I published for them a bunch as well. Like it was really a good system. But man, like I have to think what it cost. It's different funding models in the U.S. private hospital versus Canadian. But that's an amazing North Star to have. I totally agree that would be an amazing system to have in place here. Vincia Pandia, if you want to look her up, she's incredible.
All right, I'll ask everyone to continue asking questions as Rob finishes this up, and then hopefully we can save some for the end.
Yeah, we only have 15 minutes left, so that we way too many slides, Paul. What should we do?
I don't know. I can cook and then pass it over to you, and then or you can just go.
Get cooking, man. Do it. It's your slide sets. Keep going.
I'll talk about weaning in 5 minutes. Weaning with some protocol in a Cochrane review. So this is once we've trached the patient. Some sort of weaning protocol has been shown to improve the probability of weaning off the ventilator significantly with a reduction in median duration of invasive mechanical ventilation of 26% and ICU length of stay by 11%. So some protocol at a center is better than me on Monday morning or Sunday saying do this at 8 a.m. and then try this at 4 p.m. and the next person comes in the next day and changes it. Some standardized protocol is better than none. So what did we do at UH? We drew some inspiration from Martin Tobin and Jubrin's study in 2013. This was a study that looked at trach patients in terms of a randomized control model. Randomized control trial, screened people with 5 days of unassisted breathing, which was just put them on trach mask, see how they do for 5 days straight. And then if they were randomized to either trach mask or pressure control overnight, and then or pressure support, which was titrated to their work of breathing. What this study showed was, interestingly, if you put people who are trached on an unassisted breathing trial, this is in the United States, where these people would have been transferred to an LTAC, so slightly different, but a significant proportion of people, 32%, if you just put them on unassisted breathing trials, will wean immediately. And then the trach mask process of just putting people on until they fail with sequential increases in time versus trying to get their pressure support where their work of breathing down has a significant improvement in time of weaning and survival. So at UH, we started to build this trach mask trial protocol, which follows 3 basic steps, which you can see here. Establish stability, do the trials, and then wean overnight. The first thing is to not do it in the people who are not appropriate. These are all fairly straightforward. If they're in respiratory distress, unmanaged shock, cardiac ischemia, or dangerous agitation, don't start trach masking them. That seems pretty straightforward. In terms of when we would stop trach masking people, these are just drawn out of that original New England paper of what a failed SVT looks like. And so 2 of those would induce or be called a failure of trach mask trials. The first step is seeing who's ready to go onto a trach mask trial. Making people who are exhausted do this is not beneficial. So we start up in the top left corner. If they meet that criteria for stability, then we do a 2-minute CPAP trial at whatever their PEEP is. And then based on the Rapid Breathing Index or F over VT, if they pass, we go into trach mask trials. And if we fail, then we just leave them on pressure support and try and be a little bit more accurate with what pressure support level we're providing so they're not working too hard or not enough based on their P0.1. The next slide is busy and is the meat of this, but we'll start up again in the top left corner. We get our initial trach mask attempt. If it lasts for more than 15 minutes, you just continue on until they fail. And that's based on those failure criteria. So if we have somebody that we say, there's no way that this 80-year-old person is going to be able to wean, we'll do at least one day of just rip the Band-Aid off and see what they do. And I've already been surprised by the number of people. We don't say, let's just start day one with 4 hours, just go until they fail. If they last between 15 minutes and 6 hours, we increase it this is a fairly arbitrary amount. There's not a lot of science. There's no best way to slowly increase the trach mask. But the things that are relevant are we try and do it at 10 a.m. and 4 p.m. We try and do the physio, the nursing while they're on the vent, so they're not becoming exhausted and using metabolic work in order to do both at the same time. Try and do it upright. And then we recommend resting during the trach mask, either during the day or at night on CMV or ASV. We don't use pressure support overnight. They're not weaning. They're not getting there that quickly. Don't make them work overnight. Try and reduce their work of breathing and maybe improve their sleep. Once you get to the point where you're doing 10 hours a day, you go up to 16 hours, and then we consider overnight weaning. Overnight weaning involves same thing, top left corner. We look at a blood gas in the morning, and we're increasingly using transcutaneous CO2 monitoring, which is an easy bedside skin monitor to look at when they're failing. Check their blood gas a couple times in the morning, check their transcutaneous CO2, and then at the bottom right, if they do well for at least 48 hours, then we would consider them, in most cases, they're graduated from the ventilator. The final step, which I'll talk about, is decannulation. This kind of gets back to the trach team and whatnot. At UH, we had a multidisciplinary subgroup of our critical illness recovery program. So an SLP, two RTs, clinical nurse specialist, and myself met a few times to review what is the evidence around decannulation, how can we expedite it? And there is an excellent high-quality randomized control trial that was published from Spain called REDICAP. I would encourage people who are in this space to read it, published in 2020. They looked at weaning based on trach mask, oxygen, and suctioning versus just using a high flow trach, like that bullet adapter through the tracheostomy, and then and like no speaking valve, no capping, no oxygen related things, just high flow oxygen. And if you suction less than every 4 hours, you decannulate. And they showed here, this is not the same Kaplan-Meier curve. There was a significant benefit in terms of the percent of patients who underwent decannulation. There was a significant reduction in time to decannulation, which you can see here at the bottom. The median time was 6 days in the intervention group versus 13 days in the control group. So that was statistically significant with no change in failures. So the big difference in what I want to sort of wrap up with is if we look at the reasons why people fail trach masks, and then we would say, put them back on, the trach mask is over, they failed. If we saw a patient on the floor who had this, stats were fine, but they're tachypnic, they're working harder, and they're on a non-rebreather or a venti mask, we would put them on high flow. But we don't routinely use high flow. We use what's on the bottom left here, which is a trach collar. It's just blowing humidified air off into the ether. We cinch it, but it doesn't make sense why we would escalate a non-invasively ventilated person to high flow, but not invasively. So what we've tried to do, and I'll show you our little protocol at UH, is we're trying to either use this sort of adapter that goes right onto the trach and provides humidified high flow air directly in, so then we don't have to stop for those reasons. Or even better, just go right to high flow nasal with a capped or a corked tracheostomy, and then that provides humidification, it provides airway pressure maintenance. And so one of those two is what we prefer. So this is what was designed by our local group. It's still sort of in the final stages of approval, but it incorporates everything you guys have already said. The CCOP physicians, this is sort of for the RTs, and it's designed with RTs and SLPs. The RTs can come to the CCOP physician at UH and say, they've gone through the protocol, they're ready, this is the highest quality, best evidence, can you put the order in to decannulate so the medicine doc who's less familiar doesn't have to, and we work through it. And you can see here, our preferred mechanism is once you're weaned to do a cap and high flow nasal cannula oxygen, with the alternative being a high flow adapter. So I've kind of talked about this stuff, and I don't want to take up any more of Rob's time, but I will stop sharing and give him the final moments.
Love final moments. Sounds like my trauma practice. But Paul, I love the high flow adapter on the trach. We've not seen that at Vic. I know I see Anders on the call. I don't know. Is there any? Did you have to get permission for that? We always been told we can't do high flow through the trach at the Vic. How did you guys overcome that hurdle?
That was not a hurdle I would ever encounter. I don't know if our RTs are on here, but we've done it. It's been sparing because we like the speaking valve and the trach collar. We just think it's the way we do it.
Yeah.
But when we've asked for it specifically, people with high work of breathing air hunger, I've never encountered any pushback. But maybe I just wasn't aware of any. So I don't know. I can't comment.
Yeah. Well, we'll leave it offline for now. But yeah, that's a good idea. And I think the capping and high flow cannons are a nice idea too. And just really, yeah, more aggressive decannulation, the same as more aggressive extubation, right? The more we can make ourselves comfortable with doing stuff, the better, I think.
Yeah, it looks like Michelle was a big fan of that. She gave some applause there.
There you go.
That's-
Nice.
I'm
Hey, look,
so glad you put my hand up, Rob. Sorry, we can do high flow trach adapter. We do it all the time on the course.
good. I'm glad. I thought it was a bear. I'm glad it's not. And it's Michelle, it doesn't look, is it the same kind of bullet shaped one we use off the ventilator, off the airbow units upstairs, or is it a bit different?
It's the same interfaces,
Same.
both the airbow
Okay.
and the vent. Yeah.
This is good news. Hey, look we have what, like 5 minutes left. I'll do a really quick look at my last slides, which are here-ish, I think. Maybe no, that's not right. Stop that for a second. What could I share? How about this? That's better. So all I wanted to do was give some sort of like just troubleshooting advice. And again, this particular is the two things they call it a lot are bleeding and displacement on the tracheostomy tube. I would say in general, I like to look from above and see the trach tube in situ, both the time of insertion and of course later on if you're working for bleeding. If it's still got blood running down from here, revise it. And only put enough pressure in to get a seal. If you're watching and doing this, it's a great way to like put another CC in, as it's sealed. That's all we need. Because I think overinflation of the cuff, as I think Anton and Paul mentioned, is a big problem down the road. I also think that, when you look at these gaps in the skin around the trach site, one of the biggest causes of bleeding are these gaps. It allows blood to pour out. Just make sure you put a stitch in that area to actually close off the skin tighter on the trach tube. That's made the biggest difference in the number of times we get called for trach site bleeding down in the days of full tracheostomy. And then, with serious bleeding, the thing that everyone thinks it is a TI fistula. The thing it normally is suction trauma. And the only way that I think you can really prove it is not well understood, right? So you have to understand the pathophysiology that we are proposing when we imagine the specter, the ghostly like terror of a TI fistula. What you're saying is that the trach goes in, no problem. The inner artery is below the sternum. You didn't go through the sternum to get there. The trach goes in, it goes down the airway, and then lower down behind the sternum, the pressure from the cuff is eroded in and made a little hole in the back wall of the inner artery that erodes into an ulcer in the back and the front wall of the trachea. That's what you're guessing. Nothing to do with up here. You're thinking there's a problem way down here. So looking from above can't help you. Looking through and below can't help you. The area you want to see is right here. And a CAT scan can't help you because they're always going to be a millimeter apart. They're always opposed on a CAT scan. That's anatomy. The only way to know it is this way. You have to see this area. And so to do it, you have to do this. This is me, and I know it's tassel because you hear my voice.
This is the actual
Oh, it's not going to play.
yellow catheter going. It's no official there at all. So
Congratulations, Rob.
Reinsert the trach, buddy. Put it back up.
Sorry, the video failure. But what I would have been doing in that video is put an air-change catheter in, scope from above, take the trach out over the catheter, and actually remove the trach from the airway and visualize the interior wall of the trachea and say, is there or not a pulsing ulcer there? That's the only way to know. You have to remove the trach to know. And if anyone tells you they've scoped it in TI fistula, ask them, have you taken the trach out? If they haven't, then they don't know. You have to remove the trach to see the anterior wall, to see this area, pull the trach out, either with or without a change catheter, and see that area to know you don't have a TI fistula. That's just so people know.
This is the actual.
That was a Mac to West to PC failure on the video. Sorry. And literally, last but not least, displaced trachs. It is a super common problem that occurs more commonly as time goes on since the trach. And I would remind everyone that two things happen as time goes on after a trach. Patients get more awake and get moving and pulling on the trach, tipping it forward, and the trachs get shorter because someone decides to downsize it, right? So over time, it tips forward and more forward, and all of a sudden the tracheal os up against the back wall. That's just as patients move and tug, and that trach collar Paul showed hangs off it. And then someone says, oh, you know what? It's not working that well. Let's downsize. Well, a number 6 trach tube is like probably 2 centimeters shorter than the 8. Suddenly the trach is actually out of the airway and sitting in the soft tissue of the front of the neck. That's basically a fancy way to decannulate somebody, and it happens all the time. And so false passages and misplaced trachs are super common. And I generally don't downsize until I'm ready to lose the trach, right? And if I get somebody who's having that problem, I'll often change to extendable flange trach and get longer to make sure it stays deep in the airway and central and not up against that back wall from all that wakeful tugging and pulling and shortening the trach. All right. That's all I had to say about that. Does that all make sense to folks? Any last second questions at 12:59 p.m.?
That's great. I'll wait for some questions, but just before people start leaving, I want to say thank you to both of you for giving a great lecture. And, trachs are a huge topic, so that's why we're doing a part 1 and hopefully follow up with a part 2. So, monumental task for you guys to cover all that. We do have our next session booked. I'll send out calendar invites soon, but for April 3rd at noon Eastern Time, we have the Windsor group led by Dr. Ian Mazzetti talking about how to be a leader during a crisis, and in particular, the data breach that they suffered in Windsor and Sarnia area, which, is a very unique topic. I think will be very interesting. And we are going to be continuing this on hopefully for many years. With Eric back in London, we're hoping to do an in-person event sometime next year. So look out for that. And we are always open to emails, and the Google Forms is probably the best way to give us suggestions for new lectures. I'll leave that for anyone who has more questions for Rob and Paul. Oh, looks like we have 2 here. Alfazel said, even CTA neck doesn't show the TI fistula bleed.
No, can I go back? Oh, my slides again here. 1 second. So Pfizer with a capital F. Where are we here? I don't even know. I do. So can I just show you this guy here? So if remember the idea of a TI fistula, just to read the anatomy, is you have behind the breastbone is the nominal artery. It has to get from the left side of the aorta across to the right to give off the right-sided neck and subclavian vessels, right? It passes behind the breastbone and it settles in it, and it always lays right up against the trach and the front wall, okay? If there's active arterial hemorrhage from this, you will not require a CAT scan to prove it. In fact, you will not get to the CAT scan, or they'll be arresting from hemic asphyxiation. So if it's actively bleeding, Asking the question, is there a subtle ulcer? Was that a harrow bleed? Is there a problem where this is going to be a TI fistula? You can't possibly know. There's an inflated cuff that pushes the front wall of trachea and an artery like this close together. And all that thing's going to say is, yeah, I mean, they're close by. I don't know, right? It's not something you can see. You have to get this trach out of the way and look and say, is there an ulcer there? It's the same way you can't call ulcers, very well, in the GI tract on CAT scan, and they don't even have a balloon pressing the two together. So it's it's unfortunately, this particular question is not answered at all by CT angio, and it's routinely ordered, and it's not useful.
Yeah, I agree. Routinely ordered, and I'm really appreciative that you explained that out. We do have another question. Is there evidence for resting on CMV overnight rather than pressure support? And I just wanted to verbalize this because some people might not see the chat. So Paul answered there's some EEG evidence that CMV improves sleep quality. There is also some physiologic evidence that CMV reduces metabolic cost. These are not stellar clinical levels. And then he linked to a paper in the ATS, Effective Ventilator Mode on Sleep Quality in Critically Ill Patients by Martin Tobin from 2002, if anyone wants to look that up. Next comment was from Brenda Morgan. Totally opinion/observation based. I've seen catastrophic innominate bleeds, but not frequent. I think some of the issues of years ago has been improved by better trach design that allows some ability to flex the neck. Securement to take the strain away from the actual stoma is important when ambulating and turning.
Yeah, I've been involved in a couple, Brenda, none from perc trachs. They're all from radiated necks. Post-laryngectomy is the most common thing we see for sure now. And I think too, Brenda's hit the nail on the head. Being safe and smart about trach inflation. Like I watch as we inflate, I use only minimal trach pressure. If you're using a shy that has air, you can measure the pressure in a cuff, same way the RTs do with a cuff pressure in the T-tube. Those kinds of like better trachs, more compliant balloons, being thoughtful about how much pressure we exert and getting the cuff down as soon as you can, that makes the biggest difference. And truthfully, if you're wanting to like know this boogeyman, you will not likely see it in a perc trach. You will see it in a chronic trach patient or a chronic laryngectomy patient. Plus radiation is a good kind of that's who you're gonna find it in, and it's a bad problem for sure. Those, if you don't know and you meet one of those, put your finger in the hole and press forward and press this artery against the sternum is your best bet. The Utley maneuver. I've done that a couple of times, and it's definitely brought a lot more control to the problem.
Okay, I'll give another minute or two if anyone wants to either raise their hand or post in the chat for any questions for our two experts here.
Brenda's right. The last time we had operating TI fistula, it was Medi was still a fellow. That's how long ago it was. So it's been a while, thankfully.
I can remember a way longer ago one, Rob, that the patient just exsanguinated. I mean, her basic like cardiac output came out her.
Was she retired OR nurse, Brenda?
No, this way, but probably before you were born, Rob.
Scary, very scary stuff. Yep.
All right, guys. Well, on that note, I'll say thank you again to our speakers. Thank you, everyone, for joining us. And please look out for our next session on April 3rd.
Thanks, Anton. Thanks, Paul. Thanks, Eric in Calgary.
Thank you, sir. Thanks, everybody.